Hi, this is Peter Dolson, registered nurse in pathophysiology for the Advanced Practice RN, with Dr. Mark Arredondo as our professor. I'm going to be talking about chronic kidney disease. So chronic kidney disease is also known as chronic renal insufficiency. It's characterized by a loss of the ability of the kidneys to filter blood, and it's generally slow progressing but can lead to kidney failure. So it's often not recognized by patients and clinicians, and it may present without symptoms, and it generally requires routine serum chemistry and urinalysis for diagnosis. In the initial stages of tissue damage, the remaining tissue will increase its performance. That's called renal functional adaptation, and this tissue damage can result in the inability of the kidneys to maintain fluid and electrolyte hemostasis. So the damage is causing a problem with our body's ability to maintain hemostasis. So chronic kidney disease, a little history, is the 16th leading cause of years of life lost worldwide. So appropriate screening, diagnosis, and management by primary care clinicians is necessary to prevent adverse chronic kidney disease associated outcomes. And this includes cardiovascular disease, end-stage kidney disease, and death. One of the most common complications of chronic kidney disease is cardiovascular disease. And this is in contrast to acute kidney injury that's usually a result of an ischemic injury, and the decline in kidney function is rapid or generally less than 3 months. So the signs and symptoms of chronic kidney disease start with gross hematuria, and that would just be visible blood within the urine or foamy urine, a sign of albuminuria, nocturia, flank pain, decreased urine output, fatigue, poor appetite, nausea, vomiting, unintentional weight loss, pruritus or itching of the skin, mental status changes, dyspnea, and peripheral edema. So while these signs and symptoms may not necessarily be diagnostic of chronic kidney disease, the clinician should inquire about the signs and symptoms that may point to a potential systemic cause. And many of those causes are kind of common top 5 diseases that we see in the United States. So the primary risk factors for chronic kidney disease is going to be diabetes and high blood pressure. So specifically with those two, we see with diabetic nephropathy, its excess glucose causes sclerosis and fibrosis in the kidneys, which leads to a decrease in the nephron's ability to filter the blood, and that manifests as a slow progressive kidney disease. So the best treatment in this case is to treat the underlying cause and manage the diabetes. And in this case, kidney damage can lead to worsening hypertension as well. However, hypertension itself can also be a cause of chronic kidney disease. So hypertension, the way that causes chronic kidney disease can be through a process of nephrosclerosis. So in hypertension, it leads to sclerosis or thickening and hardening of the blood vessels in the nephron, and this essentially can reduce the blood flow and create both a problem with supply of blood flow as well as decreasing the glomerular filtration rate. So some other risk factors for chronic kidney disease are going to be things like heart disease, a family history of chronic kidney disease, obesity, exposure to nephrotoxins, so different types of nephrotoxic drugs or other nephrotoxic substances in the environment, history of recurrent urinary tract infections, nephrolithiasis or kidney stones. And then some additional considerations with chronic kidney disease would be things like autoimmune disease or chronic infection, or if the patient has a sickle cell trait. So with the disease, with chronic kidney disease, we have to look at the progression of chronic kidney disease, which starts at stage 1 with a normal GFR of greater than or equal to 90 milliliters per minute per 1.73 meters squared. So with chronic kidney disease, it's the progressive loss of renal function, and this is associated with usually a systemic disease, and also it's a greater than 3 months. So usually you're going to be looking at these GFRs and or the diagnostic criteria for over 3 months, which again is in contrast to an acute kidney injury, which is occurring rapidly and is less than 3 months. So the acute injury has the potential to be reversible. However, acute kidney injury also can lead to a chronic kidney disease. So the progression again starts where there's generally no signs or symptoms. However, hypertension is common in stage 1, which then leads to stage 2, which we have a GFR that's decreased to about between 60 to 89 milliliters per minute per 1.73 meters squared. And there may be subtle signs and symptoms. Hypertension is also common here. And we're going to see an increase in creatinine and urea level as the kidneys fail to excrete those. So in stage 3, this is where we start getting into more serious symptoms that are visible with a GFR of 30 to 59. So the GFR continues to decrease. We see hypertension again being common with also continued increase in creatinine and urea levels. And the KDIGO guidelines recommend the patient with a GFR below 30 should be referred to nephrology. And those guidelines are available and published on their website, which I have a reference linked. So when we get to stage 4, we have 15 to 29 is the GFR. And at this stage, we're in severe kidney damage. There will likely be accompanying erythropoietin deficiency anemia. So you may also then see anemia on the blood work. Hyperphosphatemia. So we're going to have a buildup of the phosphates in the blood. Increased triglycerides. Potentially metabolic acidosis. Hyperkalemia. Salt and water retention. And at this point, generally, it's about time to consider whether or not the patient is a patient that you're going to be thinking about doing dialysis. And this is usually based on whether or not the patient's symptomatic. So we discussed the signs and symptoms. If the patient is symptomatic, this is the point where we may want to be discussing with them if that is something they are interested in and or if it's the best treatment option for them. So once we get into stage 5, our GFR is less than 15. And this equates to end-stage kidney disease. So the patient will likely be symptomatic, and dialysis or transplant should be discussed based on the patient's stage of life and what treatment may be most appropriate for them, the stage of their disease with each client. And some clients, depending on stage of life, may choose to do nothing, especially if they're asymptomatic. Again, the guidelines can be found on the KDIGO link at the end of the presentation. So with diagnosis of chronic kidney disease, it's primarily going to be done through routine serum chemistries. So we may not see any symptoms initially in the disease. However, we may see alterations initially with creatinine elevating. We also can look at the BUN, cystatin C, and the estimated glomerular filtration rate, or GFR. So with urinalysis, we also, again, might be looking for things like albuminuria or proteinuria. And then with patients where we suspect chronic kidney disease, ultrasonography and then also sometimes renal biopsy can be used to confirm. So it's usually, again, first suspected with a rise in the serum creatinine, and then determining chronic kidney disease versus acute kidney injury is usually most helped by gathering data through their history, specifically whether or not they've had previous elevated creatinine or abnormal urinalysis. So what are the specific diagnostic criteria for chronic kidney disease? So first we're going to look at the serum filtration markers. So this would be the estimated glomerular filtration rate. And so a GFR of less than 60 for greater than 3 months is considered diagnostic. So if they meet that criteria, we should be thinking for the potential of chronic kidney disease. And then the other marker is the just kidney damage markers. So the urine albumin to creatinine ratio, or ACR, of 30 milligrams per gram for greater than 3 months. Cystatin C, also known as cystatin 3 measurement, can be added for more accuracy. And this marker is now recognized as a useful marker for kidney damage to monitor function for things like transplanted kidneys. And cystatin C is produced in the body by all nucleated cells, and it's filtered by the kidney, but it's not secreted by the kidney tubules, but it is metabolized in the tubules, so it does not re-enter the circulation. And this means that the serum concentration would then be directly proportional to the kidney function. So it can be used, like I said, as a good indicator of kidney damage. And then renal biopsy is often used to confirm the diagnosis, looking for damage to the kidney cells. So there was a recent study done that looked at patients with chronic kidney disease and whether or not the PCP or primary care provider was aware of the diagnosis. The study was looking into the efficacy of using electronic health records and data to potentially assist with improving guideline-driven care. So in the future, we may see historical lab data in the EHR being used to flag patients to assist in identifying potential chronic kidney disease and see if we're following treatment guidelines and or recommending treatment guidelines. So the study found that using just the eGFR data by itself overestimates the disease prevalence, but that CKD being listed in the problem list was linked to a high odds of testing being conducted in concordance with guidelines. So that's good that when the diagnosis was listed in the record, we are seeing a high compliance with recommended guidelines. So with treatment of chronic kidney disease, this is where things get interesting for myself. It can be summarized into kind of 6 categories in an article by Chen and Kinsley and Graham. And specifically, they are reducing cardiovascular disease or risk of cardiovascular disease, management of hypertension, management of diabetes mellitus, avoiding nephrotoxins, adjustment of drug dosing, and dietary management. So with the initial treatment, like I said, patients with chronic kidney disease, they have higher incidence of cardiovascular disease, and chronic kidney disease is associated with poor outcomes. So recommendations include things like quitting smoking, use of statins, regardless of the LDL level, and management of blood pressure to below 140 over 90 millimeters of mercury. So, and that leads to kind of the next intervention, which is the management of hypertension. This can be done with things like ACE inhibitors or angiotensin II receptor blockers or ARBs, and albuminuria should be evaluated with these patients, and dual therapy should be avoided just because there's a higher risk of hyperkalemia and potential for acute kidney injury. So there are several algorithms out there for treatment and hypertension of patients with chronic kidney disease, and those guidelines are published both in the KDIGO recommendations, as well as they are available on the NIDDK or the National Institute of Diabetes, Digestive, and Kidney Disease site. So management of diabetes then also becomes very important because it's the glycemic control is the factor that directly leads to potential kidney injury. So glycemic control may slow the progression of chronic kidney disease, and most guidelines recommend maintaining a hemoglobin A1C of approximately 7. So this is made more difficult because like oral drugs that are cleared by the kidneys should be avoided, things like glyburide. Other drugs that are partially cleared by the kidneys may also need dose adjustment, and that would be things such as like metformin. So moving on, we have nephrotoxins, and they should generally be avoided in patients, and we need to educate them to avoid things like nonsteroidal anti-inflammatory drugs, or NSAIDs, that are filtered by the kidneys. Herbal remedies should be avoided because they are not regulated by the FDA, and ones containing aristocolic acid or anthraquinones have been reported to cause severe kidney abnormalities. Then you also have things like phosphate bowel preparations or proton pump inhibitors that are available over the counter and have been associated with kidney complications. So discontinuation of proton pump inhibitors, though, is not necessary, but it is recommended that the indication should be addressed at each primary care visit. So continuing to review those medications with clients with a confirmed chronic kidney disease. So the patient's medication list should be reviewed, and each drug should be evaluated. And this is related to the adjustment of drug dosing. So there's a potential need for a dose reduction, consideration of alternate therapy, or potential discontinuation of drugs that are potentially either nephrotoxic or may have their metabolism slowed. From the perspective of an APRN in the primary care, it's crucial for us to identify clients that have chronic kidney disease and follow the recommended guidelines for management, monitoring, and the potential need for a referral to a specialist if they have not already been connected with one, and that would be through to nephrology. So in summary, with chronic kidney disease, you have a cellular injury that occurs at the nephron. It sometimes results from symptoms result from an increase in the waste products in the blood and electrolyte imbalances. And although injury is not reversible, the management of the risk factors can slow the progression. The treatment of underlying cause may aid in better patient outcomes. So chronic kidney disease results again from progressive loss of kidney function, caused most commonly by diabetes and hypertension. The cellular injury in the blood vessel in the kidney results to a decrease in the function of the nephron and a decreased GFR. As the kidney function declines, the waste products filtered by the kidneys that are not filtered by the kidneys results in uremia and azotemia. And due to a buildup of waste products, we see changes in the function of many of the body systems that result in the late signs and symptoms of CKD. So early diagnosis and control of risk factors can help delay the progression of the disease and improve the patient's outcomes. Thank you.